Okay, welcome back. Am I audible and visible to you guys? Am I audible and visible? By the way, okay, cool. So we are going to see other liver disorders right now. So the first liver disease, what we are going to see is going to be on the alcoholic liver disease. Alcoholic liver disease. So that's what we're going to see first. So we have some many basic definitions. So this will be basically 1 to maybe 1 hour session. So that's what I'm planning to take now. So the first one is the alcoholic liver disease. Remember, this is supposed to be the most common cause of liver cirrhosis in India. Alcoholic liver disease is supposed to be the most common cause of liver cirrhosis in India. But in the Western world, this is only the second most common cause. The first most common cause, I've already told you, it is typically hepatitis C virus in Western world. But in India, the most common cause of liver cirrhosis is basically the alcoholic liver disease. And the risk of getting a liver disease is directly proportional to the amount of alcohol we consume. And usually, the Western standards try to standardize the amount of alcohol drinking based on the standard drink. So, for example, we have something called one standard drink. So what do you mean by the word one standard drink? One standard drink is equal to 14 gram or which is approximately equal to 18 ml of purified alcohol. Purified alcohol. So which means we are talking about a 14 gram of 100% alcohol or probably 18 ml of 100% alcohol. So that is what typically referred to as one standard drink. But this one standard drink definition is highly variable because, for example, if you take certain countries like Australia, where 10 gram is considered to be equal to one standard drink, and if you take countries like Japan, it's 20 grams that is equivalent to one standard drink. So it is variable, but I mean, either you can use 14 gram or you can use 10 gram depending on which country you are in, depending on the authors, those who are publishing the trials. So depending on them, they can use different quantity for the standard drink. So, but standard is that 14 grams is what we take it as one standard drink in reality. So that is the United States standard. And depending on that, you can have different beverages having different amount of alcohol. For example, beer contains only 5% of alcohol. So which means to get one standard drink out of beer, you need 350 ml of beer. 350 ml of beer is equal to one standard drink. So similarly, if you take wine, which contains approximately 12% of alcohol, so that will correspond to 150 ml. So 150 ml of wine, if you take, that will be equivalent to one standard drink, approximately. Suppose if you take hard liquor, we call that something as hard liquor. Hard liquor are otherwise called as 80 proof spirits. Basically, hard liquor contains approximately 40% of alcohol by weight. So which means just 44 ml of a hard liquor will be equivalent to one standard drink. So depending on the alcohol content, your amount of alcohol needed to get into that one standard drink definition will be highly variable. So what is the recommended amount of alcohol that we should take per day? So there are something called as recommended safe limits. As far as recommended safe limits are concerned, so for men, it is less than or equal to 2 standard drinks per day. Up to 2 standard drinks is allowed for men, and for women, it is at least one standard drink per day. So up to one standard drink per day is allowed for females, for women. So that is because of the difference in the metabolism of alcohol between males and females. For males, up to 2 standard drinks are allowed, and for females, up to only one standard drink per day is allowed. So to get an alcoholic liver disease, so when you get an alcoholic liver disease, especially if you are consuming more than 21 standard drinks per week for more than 2 years at least, this is for males, and or if you're taking more than 14 standard drinks per week, at least for more than 2 years if you are a female. So this is considered as a risk factor for getting alcoholic liver disease. Remember, again, the susceptibility for getting liver disease because of alcohol is again genetically determined, and there are a lot of variations in that. But in general, to get an alcoholic liver disease or to consider that the patient is under risk of getting alcoholic liver disease. This is the definition. If you're taking more than 21 standard drinks per week for at least more than 2 years if you're a male, or if you're taking more than 14 standard drinks per week, at least for 2 years if you're a female, so there's a substantial risk of developing alcoholic liver disease in this circumstance. But this is the standard, like US definition, but Harrison will give you a different definition. For example, if you're taking more than 210 grams per week for more than 2 years in a male, or if you're taking more than 140 grams per week for more than 2 years if you're a female. So this is what Harrison tells you. But I mean, again, this is not a controversy because Harrison is using 10 grams as a standard drink definition. So it depends on the authors. Different authors can use different standard drink definitions. So that is why it's better to use this kind of grams, which will avoid confusions rather than using the standard drink based definitions. Even though in United States, the standard drink based definitions are the popular ones. So they are the ones that are very commonly used. But in Harrison, they will give grams based alcohol. This is more accurate, to be honest. So they're using 10 gram as one standard drink, but here one standard drink is equal to 14 grams of alcohol. Nevertheless, so this is the idea. That's what you should know. And substantial increase of alcoholic liver disease is there whenever the patient is taking more than 210 grams per week of alcohol or more than 140 grams per week of alcohol. I told you what is the amount of alcohol in different liquors. And what are the examples of hard liquor, by the way? Everyone knows that people are consuming alcohol. Many of the medicos do consume alcohol, so they have to know that. So you have whiskey, you have gin, you have vodka, and tequila shots. All these things will be basically coming under the 80 proof spirits, or otherwise referred to as hard liquor. So they contain very high levels of alcohol. So nevertheless, so this is the basics of getting an alcoholic liver disease in the first place. So then what is the pathophysiology? Why you really do get alcoholic liver disease in the first place? Because alcohol generates excess NADH. That's the most important problem. You know, when you have ethanol, first it will be acted upon by something called alcohol dehydrogenase. So that is going to produce one molecule of NADH, and that will result in the generation of acetaldehyde. And this acetaldehyde will be further acted upon by something called as aldehyde dehydrogenase. Aldehyde dehydrogenase, and in the process it's going to produce another NADH, which is going to produce acetic acid or acetate. That's what you're going to call it. So which means you are producing two NADH in the process. So NADH is basically energy rich compound, by the way. So when you are producing excessive NADH because of alcohol metabolism, and this is where the key thing is. So whenever in the liver cell, which is the primary site of metabolism of alcohol, you are going to generate excess NADH, and this increased NADH is like energy full state in the liver. Like whatever, the liver assumes whenever there is an alcohol, whenever there is more NADH, the liver assumes that is an energy replete state or an energy full state. It's a sign of energy replete state in the cell. So what they do is whenever the liver cell thinks that it's a sign of energy repletion, they will go for storage of energy. So what kind of storage? For example, they increase the production of fat. For example, the glycolytic intermediates will be shunted towards the production of fat because only when you do not have energy, so that time you can mobilize the fat stores, produce lipolysis and produce energy. But when you have too much of energy, like abundant NADH within the cell, they believe that there is too much of energy already. Then why you want to really produce ATPs rather than try to shunt this energy towards the storage of energy in the form of fat. So they're going to produce more fat. They're going to produce the shunt the glycolytic intermediates to produce this glyceraldehyde 3-phosphate and dihydroxyacetone phosphate, and the glycolytic products like pyruvate and all these things will be shunted towards the production of fat. So that's what is going to happen. So more fat means steatosis will be there. And over a period of time, this steatosis is going to produce inflammation and attracts inflammatory cells through a different process called steatohepatitis. And later on, there will be significant injury to the liver cell. And this will continue until the patient gets cirrhosis. This is what is going to be the pathophysiology. So the key point to understand here is alcohol makes the liver cell believe that the cell is full of energy because of the excess generation of NADH, because NADH is an energy-rich compound. And because of the energy-rich nature that the cell is believing to have, so they're shunting their products towards the storage of energy, because when you have so much of energy, you have to store it. So to produce storage, you have to produce more fat. To produce more fat, and when you produce more fat, that's called steatosis. Then later on, they produce something called steatohepatitis. Later on, continued inflammation will result in development of cirrhosis over a period of months. This is what is going to happen. So there are two types of disease that you can get. One is a simple alcoholic fatty liver, which is a completely reversible stage. No problem at all. Here the patient will be asymptomatic. It's completely reversible. It's just a radiological finding where the patient will have a little bit of altered echo texture of the liver because of the high fat. So in ultrasound, you might be seeing increased liver echoes, increased liver echogenicity. So this is the characteristic feature. Apart from that, in CT, you will see decreased attenuation compared to the surrounding structure. So this is a sign of a fatty liver once again. And once again, in biopsy, you will be just seeing steatosis. You will not be seeing any steatohepatitis. You will just be seeing steatosis here. And to be honest, you cannot differentiate from non-alcoholic fatty liver disease. So which means there is absolutely no differentiation with non-alcoholic fatty liver disease in biopsy. If you do histology, even in non-alcoholic fatty liver disease, you will be seeing only steatosis. Suppose if they ask you what is the most important differential diagnosis for alcoholic fatty liver, it's the non-alcoholic fatty liver disease. Then what will be the differentiation between non-alcoholic fatty liver disease? In reality, only two things will tell you that the patient is having alcoholic fatty liver disease and non-alcoholic fatty liver disease. That is the history of alcohol consumption. So whenever the patient is having significant history of alcohol consumption, I've told you what do you mean by significant history of alcohol consumption. If you have this history that goes towards alcoholic liver disease, when you do not have any significant history of alcohol consumption, then it is unlikely to be alcoholic liver disease. Then in that setting, you can think about a non-alcoholic fatty liver disease. Then second thing that differentiates, suppose in case if LFT is deranged, if liver function tests are deranged, it's very uncommon to happen in a non-alcoholic fatty liver disease stage. But in case if LFTs are deranged, typically your AST levels will be more than ALT levels. So this is very, very important. So these two things will go towards an alcoholic liver disease rather than a non-alcoholic fatty liver disease. Because in non-alcoholic fatty liver disease, one of the important things to happen is ALT levels will be more than AST, which we'll be discussing subsequently. On the other hand, second disease, what they can develop is, alcoholic hepatitis. This is the second disease they can develop, which is very important for your exam, the alcoholic hepatitis. So alcoholic hepatitis patients will definitely be symptomatic. 100% they'll be symptomatic. Usual symptoms will be that constitutional symptoms like fever, fatigue, anorexia, weight loss, a little bit of tachycardia may be there. And plus or minus, they might have a tender hepatomegaly, especially in the right upper quadrant pain. You know that. One of the important cause of tender hepatomegaly, apart from viral hepatitis, is alcoholic liver disease. So tender hepatomegaly. Here the liver will not be enlarged and it will not be tender in the first place. But in alcoholic hepatitis, liver will become tender and it can be palpated as well. So tender hepatomegaly is very characteristic. So apart from that, plus or minus they can have jaundice, plus or minus they can have splenomegaly, and plus or minus they can have signs of portal hypertension like ascites also. And even in extreme scenarios, if the hepatitis is very severe, they can have signs of liver cell failure also. They can even have evidence of failure. Like for example, they can have an elevated PTANR and they can even have encephalopathy also. It's like any other hepatitis. For example, a severe viral hepatitis can result in development of acute liver failure. Similarly, severe alcoholic hepatitis also can result in development of acute liver failure. So it's one of the reversible cause of acute liver failure as well. So how will you understand in the first place? So most importantly, the LFTs are very important. LFT wise, definitely it will be deranged. AST, ALT both will be elevated, but AST elevation will be definitely more than ALT elevation. And we know what is the ratio. Typically, the AST ALT ratio will be more than or equal to 2:1. So this is what we refer to as the famous de-Ritis ratio, which we have discussed multiple times in the past. I'm not going to discuss that anymore. And at the same time, many of these patients will have increased bilirubin. Many of these patients will have increased PTANR. Many of these patients may have encephalopathy, and these are characteristic LFTs of alcoholic hepatitis. And if you're going to do an ultrasound, you can see hepatomegaly, which is not a very prominent feature of alcoholic liver disease, but in alcoholic hepatitis, the hepatomegaly may be very prominent. At the same time, you will be seeing fatty liver as well. So once again, CT will not show much. CT will also show hepatomegaly, plus they will show reduced attenuation, and that is characteristic feature of a fatty liver. And once again, in histology, you will not see steatosis alone. You will be seeing steatohepatitis, which means there is surrounding inflammation as well. Here you have seen only steatosis, but here you are seeing steatohepatitis. hepatitis, which means there will be a lobular inflammation. We know this is a classic hepatic lobule. There will be inflammations in the hepatic lobule. So that is steatohepatitis. It's not just steatosis anymore. You will be seeing steatohepatitis. Plus or minus, you can see something called as Mallory-Denk bodies. Mallory bodies. This is not always seen. And the two things you need to know about Mallory bodies is Mallory bodies doesn't mean that you have alcoholic hepatitis. At the same time, absence of Mallory bodies does not rule out alcoholic hepatitis. Clear? So what are basically this Mallory bodies in the first place? Can anyone tell what do you mean by Mallory bodies? So what are Mallory bodies, by the way? What are Mallory bodies, by the way? So what are they made of? They're also called as Mallory-Denk bodies. Yes, correct. So they are actually made of intermediate filaments. And I mean, did not tell intermediate filaments. They are made of misfolded intermediate filaments. Typically, the cytokeratin 8 and 18. So plus they will have some P16 also, plus or minus they can have ubiquitin also. These are Mallory bodies basically. At the same time, very commonly they will be seen in, most commonly they will be seen in balloon hepatocytes. There is something called balloon degeneration, which is very common in any hepatitis. So most common in balloon hepatocytes, you can see these Mallory bodies. Balloon hepatocytes is where you are going to see the Mallory bodies very common. Clear? And even after cessation of drinking, it can persist for a long time. And the presence of Mallory bodies increase the risk of development of cirrhosis or increase the risk of progression to cirrhosis. This is a point that will be asked in exam for sure. Increase the risk of development of cirrhosis over a period of time. So increase risk of progression cirrhosis associated with Mallory-Denk bodies. But remember, I told you only plus or minus, which means even in a patient with alcoholic hepatitis, Mallory bodies may or may not be there. And at the same time, even after resolution of alcoholic hepatitis, Mallory bodies can persist for a long time. Even after stopping of drinking, Mallory bodies can persist for a long time. At the same time, absence of Mallory bodies does not rule out a alcoholic hepatitis. So only one point that is very, very important for exam is it has an increased risk of progression to cirrhosis, which is a multiple times asked question. It is made of cytokeratin 8 and 18 plus P16 plus or minus ubiquitin. These are basically misfolded intermediate filaments. So plus or minus, there can be evidence of fibrosis also. Remember, like how in a viral hepatitis, we saw patient can get a flare. That is called as acute on chronic viral hepatitis. Similarly, patient who's having a pre-existing cirrhosis can have a acute alcoholic hepatitis on top of pre-existing cirrhosis. That is also possible. Suppose the patient is already having an alcoholic cirrhosis, taking a sudden bout of alcohol, sudden binge of alcohol, that can result in development of alcoholic hepatitis on top of pre-existing cirrhosis also. So you can see associated fibrosis in patients with alcoholic liver disease as well. So this is what is going to be the typical picture. But please understand, using CT, ultrasound, and biopsy, you cannot differentiate something called as NASH. That is called as non-alcoholic steatohepatitis. So how will you differentiate NASH? To tell it's an alcoholic hepatitis, number one, once again, you need to have a significant history of alcohol. You know what you mean by significant history of alcohol. We have discussed that already. There's no doubt about that. And second, one more important thing that you need to know is the patient, the characteristic LFT, where AST ALT ratio will be more than or equal to 2:1, or AST levels more than ALT, which is very characteristic feature of a alcoholic hepatitis. Very, very important. So these are the only two things in reality that can tell you that it's an alcoholic hepatitis and it is not a NASH. But nevertheless, in ultrasound, in biopsy, in CT, whatever may be the other investigations you do, you cannot really differentiate a non-alcoholic steatohepatitis from alcoholic hepatitis. Remember, alcoholic fatty liver disease cannot be different from non-alcoholic fatty liver disease unless and until you have that significant history of alcohol, along with maybe if LFT is deranged, you can think about LFT related change. But alcoholic hepatitis, once again, the closest DD which cannot be differentiated by biopsies, ultrasound or CT is the non-alcoholic steatohepatitis, which is exactly going to produce the same change in biopsy like alcoholic hepatitis. But only thing that will differentiate is the history of significant alcohol consumption and the LFT derangement. That is classic of a alcoholic hepatitis, that is D-reduced ratio, AST-ALT ratio more than or equal to 2:1. So again and again, I'm telling you, biopsy cannot differentiate between a non-alcoholic steatohepatitis from alcoholic hepatitis, and biopsy cannot differentiate you from alcoholic fatty liver disease from non-alcoholic fatty liver. The only thing that differentiates is the history of alcohol. Maybe if LFT is deranged, the AST levels more than ALT usually goes towards a alcohol-related liver disease. So this is what is going to happen. Remember, this alcoholic hepatitis is partially reversible. I can call it as maybe partly reversible. It's not even though fully reversible. It's maybe partly reversible. That's what we can tell. It's not fully reversible. Maybe completely reversible in some mild cases, but sometimes it may or may not reverse. The next step is progression to cirrhosis. Cirrhosis, once again, is destruction of liver architecture. So ultrasound typically will show, maybe even CT typically is going to show nodular liver, and patients may have signs of portal hypertension, plus or minus, when you do a biopsy, of course, you don't do a biopsy in a nodular liver because you're not going to get anything. You will be seeing only destruction of liver architecture with multiple nodules. Along with that, you're going to see that fibrotic collagenous bands. Fibrotic bands is what you're going to see. So these are the characteristic features of cirrhosis. But initially, it starts with alcoholic fatty liver disease, then progress to alcoholic hepatitis, then slowly it starts progressing towards cirrhosis over a period of time. Once you develop cirrhosis, we know it is completely irreversible. Completely irreversible. So alcoholic fatty liver, completely reversible. Alcoholic hepatitis, partly reversible. Cirrhosis is an irreversible stage. So that's what is going to happen. But cirrhosis, non-alcoholic fatty liver disease, there is only one treatment that is required. You're not going to manage with any big thing here. You just need alcohol cessation, that's all. Stop taking alcohol, that will completely cure the disease. Cirrhosis is the other end of the spectrum, and there is no much treatment available. The standard cirrhosis treatment is what we're going to do. The only option is treat the cirrhosis with conservative management. If it doesn't respond over time, you have to go for liver transplantation. So that is the only thing that you can do. Standard cirrhosis management. There's no particular treatment that is available for patients with cirrhosis. So these patients with alcoholic hepatitis, of course, apart from stopping the alcohol, there are some drugs that are proven to be beneficial in patients with alcoholic hepatitis. The one thing is prednisolone. One thing is prednisolone, steroids. So they will ask you what is the indication for steroids. The number one indication for steroids is the discrimination factor more than 32. Or we call it as discrimination function more than or equal to 32, or simply called as matrix discrimination function more than 32. Discriminant function. So what do you mean by discriminant function, or otherwise matrix discriminant function? So discriminant function formula is there, which can be calculated by, it's a very important one for exam, 4.6 multiplied by PT, that is test minus control, plus total serum bilirubin. Plus total serum bilirubin. So this is the basic matrix discriminant function. So for example, let us calculate, because in exam they'll ask you to calculate. How will you calculate a matrix discriminant function? Ankit is asking, so NAFLD cannot be diagnosed in the presence of significant alcoholic history, even if the inflammation is not because of alcohol. In the presence of, first of all, one question to Ankit is, first of all, if the patient is having significant alcohol history, how can you tell that the inflammation is not due to alcohol? It must be due to alcohol. So remember, NAFLD is a diagnosis of exclusion. How you have diagnosed hepatorenal syndrome as a diagnosis of exclusion? You rolled out so many things and then you have diagnosed hepatorenal syndrome. Similarly, this fatty liver, only ruling out all the other causes of fatty liver, you can tell that it is due to non-alcoholic fatty liver. So even if the patient is having hepatitis C, I will tell that, what is that? Even if the patient is having hepatitis C virus, I will tell if the patient is having fatty liver, that fatty liver is due to hepatitis C virus and not due to NAFLD. NAFLD is totally a diagnosis of exclusion. Not reversible cessation of alcohol. If it's not reversible cessation of alcohol, then it means patient has taken so much significant amount of alcohol so that it went on to a irreversible stage. That's what I'm going to take. So you cannot really, in the presence of significant alcohol history, I will not really take that disease as a non-alcoholic fatty liver disease. So that is basically violating your rule. That is basically violating your law. You're calling it as non-alcoholic fatty liver, and the patient is having significant alcoholic history. And how can you tell it's NAFLD? So that is a kind of controversial statement we are making. So we cannot do that. So if the patient is having significant alcohol history, it is alcoholic liver disease. That's all. patient does not have significant alcoholic history, and the patient is having steatosis, not explainable by any other causes that produces steatosis, you can then think about non-alcoholic fatty liver disease. So let us see an example of how to calculate discriminant function probably. So DF. So let us assume a patient's total serum bilirubin is 10, and second is let us assume the prothrombin time is maybe 35 seconds, and let us assume this is the test value and the control value is 28 seconds. I'm telling a real life example. So now calculate the matrix discriminant function. So I think it will be 4.6 multiplied by 35 minus 28 is 7, plus 10 is the total serum bilirubin. So I think you'll be getting around 28 plus 4.2 is 32.2 plus, I think you'll be getting around somewhere around 42.2. Definitely here the score is more than 32, so that becomes an indication for steroids. So you can start with prednisolone. So one of the important indications for prednisolone is discriminant function more than or equal to 32. So remember, steroid is a double-edged weapon. So number one, so you should not use, you have to look for contraindications for steroids. So there are some few contraindications for steroids. The first contraindication for steroid is active UGA bleed. Whenever the patient is having active UGA bleed, you don't give steroids. Second, if the patient is having active infection, especially bacterial or fungal infection, we are not going to give steroids. Suppose if the patient is having associated hepatitis B virus or hepatitis C virus infection, generally we don't give steroids. These are three major contraindications. Renal failure was a contraindication once upon a time, but right now it's not a contraindication. But UGA bleed, active infection, especially bacterial and fungal infection, and hepatitis B and hepatitis C virus infection is actually a contraindication for giving steroids. What is the dose of steroids? Number one, you have seen the contraindication. Number two, dose of steroids. Dose typically we use 40 milligram per day, minimum for 28 days. 40 milligram OD of prednisolone minimum for 28 days, then followed by tapering doses for 16 days. Over 16 days you will taper. So for 28 days minimum you have to give 40 milligram. Then over 16 days we need to taper. Suppose if the patient show poor response, so which means when you start with steroids, you cannot make sure that you give for 28 days for sure. So you need to assess response at 1 week. At first week, after 1 week of giving steroids, you have to assess the response. See the response. The response is assessed with something called a Lilly score. This is something which is very important for exam. It's a complicated score. No need to know the parameters, but nevertheless, you need to know the name. So we have something called a Lilly score. As far as the Lilly score is concerned, if the Lilly score shows some improvement, you can continue steroids after 1 week. If the patient does not have any improvement based on the Lilly score, then you can discontinue the steroids. There is no point in continuing the steroids anymore. So, which means usually the score, Lilly score of more than 0.45 at 1 week usually indicates poor prognosis. And it's better to withdraw steroids. There's no point in giving steroids anymore because the patient is not showing any substantial improvement with steroids. Suppose if you have contraindication steroids, then alternative steroids is there, that is pentoxifene. Pentoxifene has been proposed as a potential alternative to steroids. Clearly, it's a phosphodiesterase inhibitor, we know that. So it is supposed to be a potential alternative to steroids. Pentoxifene has been shown benefit in some trials, but nevertheless, like it's not that great as that of steroids. Even MELD scores are useful. Sometimes if your MELD score is more than 11, and if the patient is having alcoholic hepatitis, that shows increased 30-day mortality. 30-day mortality is very high, even if the MELD scores are going to be very high. So, but usual question, okay, fine. So what is the nutshell? So to understand the spectrum of alcoholic liver disease, one is the fatty liver, completely reversible, alcoholic hepatitis, partly reversible, depending on the severity once again, and treatment depending on the discriminant factor. You can add steroids or probably pentoxifene if there are contraindicated steroids. DF more than 32 is the indication for steroids. I told you how to calculate the DF. Assess the response at 1 week using Lilly score. Lilly score is more than 0.45 at 1 week. Then it's better to withhold steroids because the patient is having a poor prognosis and they won't show much response to steroids if the patient is not responding at 1 week. So then the final stage is cirrhosis. Once you get the cirrhosis, it's reversible and you're going to give a standard cirrhosis management, and there is no doubt about that. So these are the three spectrum of alcoholic liver disease, by the way, all of which are very, very important to know. And we do have non-alcoholic fatty liver disease. And already I told you how to diagnose non-alcoholic fatty liver disease. In exam, it's very simple. non-alcoholic fatty liver disease, and they can develop NASH over a period of time, which can go for cirrhosis over a period of time. So it's been assumed that NASH is supposed to be the most common cause of cryptogenic cirrhosis. What do you mean by cryptogenic cirrhosis? Cryptogenic cirrhosis. Cryptogenic cirrhosis means the patient presents with cirrhosis for the first time, and you cannot identify any cause, and they don't have any identifiable cause. So, like, they don't have viral background, they don't have any alcohol history, they don't have any metabolic problem like Wilson disease, or they don't have autoimmune hepatitis to suggest like ANA will be negative. So there is no other cause to explain the cirrhosis. So that's what we refer to as a cryptogenic cirrhosis, but the patient has cirrhosis. And the most common cause of cryptogenic cirrhosis in the world, that is unexplained cirrhosis in the world right now, is NASH, that is non-alcoholic steatohepatitis. Usual associations associated with obesity, metabolic syndrome, or features of metabolic syndrome. Then there is something called hair-hand syndrome. Everyone would have known this. So hyperandrogenism, insulin resistance, acanthosis nigricans is what we refer to as hair-hand syndrome, and any condition that produces insulin resistance can be associated with non-alcoholic steatohepatitis. How will you diagnose NASH? I mean, any spectrum of non-alcoholic fatty liver disease. How will you diagnose really? Number one is absence of significant alcohol use. That's the number one point. That's the first thing you have to rule out. And second thing is the LFT. Typically in NAFLD, LFT may be completely normal, but usually the AST-ALT ratio will be less than 1. AST-ALT can be elevated, but AST-ALT ratio will be less than 1 in this particular situation. And please understand, the most common cause of LFT derangement, or we can call it as most common cause of asymptomatic LFT derangement in an OPD patient, is NASH. So most of the patients, sometimes you see randomly you do an LFT for some other reason, you see LFTs are mildly deranged, like maybe OTPT. Normal OTPT is less than 40, but in the range of maybe 50s, 60s, 40, just above 40s. So usually this range is very commonly due to NASH or non-alcoholic fatty liver disease. The most common reason for asymptomatic deranged LFTs in the OPD setting is NASH, non-alcoholic fatty liver disease. Clear? And at the same time, you cannot tell anything with ultrasound, because ultrasounds will show increased echoes. That is because of the fat. Fat will show increased echoes. So how will you compare the echoes? I mean, I didn't tell you this. So how will you tell with this increased echoes? In ultrasound, you generally compare with the echoes of the renal cortex. So when you compare the echoes of the renal cortex, the liver has more echogenicity compared to the renal cortex. That's what we call as increased echoes. And in CT, you will have reduced attenuation. So to which you should compare, you have to compare with the spleen. When you compare the splenic attenuation versus the liver attenuation, the liver and spleen usually will be same. In CT, if you have a lesser liver attenuation compared to the spleen attenuation, that is abnormal and that is considered to have more fat. And MRI is said to be the most accurate to assess the fat. Remember, even though we don't use this in reality, but MRI is supposed to be the most accurate in assessing the amount of fat in the liver. And MRI in certain sequences, they will show increased fat signals, which can be easily assessed in MRI, but that is the gold standard for assessing the amount of fat in non-invasive gold standard to assess the fat in liver. So invasively, biopsy is the gold standard, but overall also biopsy is the gold standard. But non-invasive way of assessing the fat in the liver is MRI. That's the gold standard. Clear? And MR spectroscopy can be used sometimes, or you can use even MR spectroscopy. Typically, more than 5% fat in MR spectroscopy tells you that the patient is having. So if the patient is having more than 5% fat in the liver, that is supposed to be diagnostic of a fatty liver. But number 4, you can do a biopsy. Biopsy can show just steatosis. Clear? Just show they will steatosis. Steatosis, that's called a bland steatosis. That is stage 1. Then they can show steatohepatitis. Then they'll progress to a stage of steatohepatitis. This steatohepatitis will progress towards fibrosis and cirrhosis over a period of time. And all these 3 things can be seen in the same patient. But depending on which is there, if only steatosis is there, that is stage 1. If the patient is having steatohepatitis, that is stage 2 or stage 3. If the patient is having fibrosis, that becomes stage 4 non-alcoholic fatty liver disease. And he has some biopsy scoring systems also. As far as the biopsy scoring systems is concerned, one of the important score is NAS score. So that's what they will ask you. What do you mean by NAS score? That is called a non-alcoholic fatty liver disease activity score. NAS stands for non-alcoholic fatty liver disease. NAFLD activity score. Again, NA stands for non-alcoholic fatty liver disease activity score. That's what we refer to as something called as NAS. So usually there are three key components. The components of the NAS score is what is very commonly asked in exam. So like all the other exams, the components is what they will ask. So one of the, I mean, you can remember the components by using a mnemonic called SBA. This is the mnemonic. So S stands for steatosis, amount of steatosis, and B stands for ballooning degeneration, and C stands for lobular inflammation. How much lobular inflammation is there? So this has a score of 0 to 3, this has a score of 0 to 2, and this has again a score of 0 to 3. So you can see the total score will be 8. So 3 plus 3 plus 3 is the maximum score. The maximum score will be 8 and the minimum score will be 0. Suppose in the absence of significant alcohol history, if it's 0 to 2, score is 0 to 2, then it will be called as no NASH. If the score is of 3 to 4. So NASH I should write in a capital letters. So no non-alcohol steatohepatitis, the score is 3 to 4. Then it could be a probable NASH. It is indeterminate. Anything more than or equal to 5. Score of 5 to 8 tells you that definite NASH. Again, in the absence of significant alcohol history, and if you do not have any other conditions that produce steatosis, in that condition you can tell about NASH. Then you have a separate fibrosis score also that is there, but it's not important for you. But this components of the NAFLD activity score is what is something that is very important and you will be asked in exams. So SBA is the mnemonic. S stands for steatosis, B stands for ballooning, and I stands for lobular inflammation. And remember, so how will you diagnose? Remember one more time. I'll tell you how you make a diagnosis. Number 1, absence of significant alcohol history. Number 1, that is the most important. Second, rule out other conditions that produce steatosis. I will tell you what are the other conditions that produce steatosis. And at the same time, third thing is, plus or minus, deranged LFTs. Deranged LFTs, typically AST will be more than ALT. And typically, investigations will show fatty liver. I can write radiological investigations. Maybe I can write ultrasound. Will show fatty liver, nothing else. And number 5, biopsy will show steatosis or steatohepatitis or fibrosis. Any one of these can be there. So this is how you diagnose a non-alcoholic fatty liver disease. But most important is, we know there should not be any significant alcohol use. That's fine. But you also have to rule out other conditions that produces steatosis. What are the other conditions that produces steatosis typically? Very important in our country to rule out hepatitis C virus, especially genotype 3. I've told you multiple times in the past, genotype 3, which is very common genotype of hepatitis C virus in India, is very, very well known to produce significant steatosis. And you have to rule out Wilson disease. Wilson disease also can cause steatosis. Many nutritional conditions can produce steatosis in the liver. Like for example, severe starvation can produce steatosis. Protein energy malnutrition can produce steatosis. And total parental nutrition can produce steatosis. Rapid weight loss can produce steatosis. Bariatric surgeries, once again due to rapid weight loss, can produce steatosis. You have to rule out all these conditions. Then you have to rule out certain medications that can produce steatosis, which is very, very important. Like for example, methotrexate, valproate. You can get with tamoxifen, estrogens, amiodarone, and diltiazem, antiarrhythmic drugs. Amiodarone, diltiazem. All these drugs can produce steatosis. In that, if you ask me one thing that is the most important, that is valproate. Valproate causes liver injury by steatosis only and steatohepatitis only. That's why this is the most important. If you want to remember only one drug, remember valproate. Most of the time, this is what you will get in exam. And you have to rule out A beta lipoproteinemia. It's also cause of steatosis in the liver. And apart from that, you have something called Reyes syndrome. We know Reyes syndrome. Again, you will have steatosis in the liver. And there is something called acute fatty liver of pregnancy. Completely, it can be easily ruled out because that will happen in the setting of pregnancy only. Then HELLP syndrome can produce steatosis. And once again, it is a finding of pregnancy, no problem. And many inborn errors of metabolism also can result in development of cirrhosis. But to our understanding, the most important thing, at least the significant thing in our clinical practice you have to rule out, is hepatitis C virus. Very, very important. And second is medication like valproate. So at least these two things is very, very important to rule out. Other things may be very obvious. Wilson will be having other features. Nutritional problems will be clearly seen in history when the patient is severely malnourished. are having a rapid weight loss, undergone a bariatric surgery, then that is a difference. So history-wise, you can easily find out all these things. But at least for our exams or for our clinical knowledge, the two most important things that has to be ruled out is drugs and hepatitis C virus, which can cause significant amount of steatosis in the liver. So you have to rule out all other conditions that produce steatosis. Along with you have to rule out significant alcohol use. Along with it, you might have a deranged LFTs where AST will be more than ALT, and ultrasound will show definitely fatty liver, and MRI and CT all will show excessive fat in the liver, and biopsy will show either steatosis or steatohepatitis or fibrosis sometimes. All these three things can be there in the same patient. So, which means typically NAFLD or NASH is a diagnosis of exclusion, by the way. Diagnosis of exclusion. You cannot diagnose NASH based on any particular investigation. It's a diagnosis of exclusion. That's all. There are many scoring systems to tell the severity of NASH. So you know the patient is having non-alcoholic fatty liver disease. You have to assess whether the patient is having significant fibrosis or not. What are the markers of significant fibrosis as far as NASH is concerned? So number one, we use something called AST-ALT ratio. Remember, AST-ALT ratio will be less than 1, but generally, usually, normally in NASH, it will be less than 0.6. But if it's more than 0.8, this increases the risk of fibrosis, advanced fibrosis in non-alcoholic fatty liver disease. So which means patients can go for cirrhosis. And we have something called a FIB4 score. This is also for non-alcoholic fatty liver disease only. Remember, all these scores are applicable only for NAFLD. It is not applicable for any other liver disease. You have to use only for NAFLD. So what is the calculation? So age multiplied by AST divided by platelets multiplied by square root of ALT. So this is what we call as FIB4 score, which means it has 4 parameters: age, AST, platelets, and ALT. So score more than 3.25 increases risk of advanced fibrosis. Increases risk of advanced fibrosis. Less than 1.45, literally a reduced risk of fibrosis, which means the patient usually will not have fibrosis. The score is less than 1.45. If it's more than 3.25, there is a substantially higher risk of having significant fibrosis in the patient. Then we have something called a BARD score. BARD score is an acronym where B stands for BMI and AR stands for AST-ALT ratio, and D stands for diabetes mellitus, especially type 2, not type 1, type 2 diabetes mellitus. So this is BARD score. Remember, each will carry, this BMI will carry 1 point, AST-ALT ratio, if it is more than or equal to 0.8, it will carry 2 points, and type 2 diabetes will carry 1 point. So any score more than or equal to 2, there is it's a ruling out score. So any score less than or equal to 2 rules out advanced fibrosis. It's very unlikely to be having a significant fibrosis. This is the third score, BARD score. Then we have the last score that is called as APRI, that is called AST platelet ratio index. So where we take the actual AST divided by AST, that is actual AST of the patient, divided by AST, that is the upper limit of normal according to your laboratory, and this will be further divided by platelet count in lakhs. So this is what we call as AST platelet ratio index. Anything more than 1.5 predicts advanced fibrosis. Less than 0.3 to 0.5 rules out significant fibrosis, but anything more than 1.5 tells you it is an advanced fibrosis. And finally, we have something called NAFLD fibrosis score. NAFLD fibrosis score. There are various components that it uses. So one is the age, second is the BMI, and of course the AST-ALT ratio, then diabetes mellitus, especially type 2 diabetes mellitus, then platelet count, albumin, so many parameters it will be taking together and will give a score. Any score more than 0.675 according to NAFLD fibrosis score tells you that the patient is having advanced fibrosis. Anything less than minus 1.455 tells you the patient is not having fibrosis. Anything more than plus 0.675 tells you the patient is having advanced fibrosis. So these are the different scoring systems available. But please understand, this scoring system should be used only after diagnosis of NAFLD. So which means you have already diagnosed NAFLD using the criteria I have told you. So now you are sure that the patient is having a non-alcoholic fatty liver disease. Once you know that the patient is having non-alcoholic fatty liver disease, then only you should use all these scores to predict the risk of fibrosis. These are the non-invasive ways to predict the risk of fibrosis. But if you want to know the fibrosis, the gold standard is always biopsy. Biopsy is the only thing that can tell you how much fibrosis is going on. whatever I have told you, whatever the parameters I have told you are non-invasive ways of predicting fibrosis. These are not invasive ways of predicting fibrosis. These are non-invasive ways of predicting fibrosis. Clear? So, but the gold standard for predicting fibrosis is always the biopsy. Invasive method is the gold standard. Whatever ways I told you are non-invasive methods. So, treatment. So, how will you treat a non-alcoholic fatty liver disease? Number one, weight loss. Weight loss is very important, but please understand, rapid weight loss itself can exacerbate this. Steatosis, which I have told you already. Rapid weight is one of the important causes of steatosis. So never go for rapid weight loss. Weight loss should be very gradual, and it should be at least minimum of 7 to 10 kilograms. Produces substantial improvement in the liver profile. So at least minimum of 7 to 10 kilograms weight loss, and it should be very gradual. It should not be rapid. Rapid weight loss itself will produce more cirrhosis. And weight loss can be achieved by different methods. So one is drugs, and second one is the surgery, that is bariatric surgery. In exam, surely they will ask you, so what are the drugs that are currently approved? One is orlistat, which is a lipase inhibitor that is approved. Most common side is GI disturbance, but otherwise it's well tolerated, but produces very small amount of weight loss. Second is liraglutide, that's a GLP-1 receptor agonist. This is the single drug that produces maximum weight loss, and you can get with combination drugs like phentermine and topiramate combination. This is a combination that achieves maximum. Overall maximum weight loss will be achieved with phentermine topiramate only. But liraglutide is a single drug that achieves maximum weight loss. But overall most common is the combination. That is the phentermine topiramate combination. Each and everything has significant side effects, of course. Then you can use another combination called bupropion and naltrexone combination. You know, naltrexone is an opioid antagonist. Bupropion is an antidepressant. That is NDRI. That is norepinephrine dopamine reuptake inhibitor. That is the mechanism of action of bupropion. But usually, very commonly, what they will ask you is bupropion contraindication. Bupropion is contraindication in patient with a seizure disorder because bupropion lowers seizure threshold. Very common question in exam. Because bupropion is not only used for weight loss, bupropion is also used for smoking cessation. It's one of the important drugs that's used in smoking cessation. So both in smoking cessation and in weight loss, bupropion is used. So they will ask you this: what is the contraindication? That is seizure disorder, because bupropion lowers seizure threshold, which is very, very important. And each and everything has a unique side effect profile and unique contraindication, which is something we don't want to discuss right now. Liraglutide, you know, it's a GLP-1 receptor agonist, which is used for diabetes. Basically, you have to, if you really know the FDA approved compounds for liraglutide, there is two things. One is called Victoza and second is called Saxenda. These are the two brands that are available. But Victoza is approved only for patients with type 2 diabetes mellitus. Saxenda is the one that is approved for using in weight loss. But this is something which is not needed for you. If you are an undergrad, definitely this is not needed. But there are different formulations of liraglutide itself. But liraglutide is something that is approved for utilization in weight loss. It's a GLP-1 receptor agonist. It's a single drug, but produces, among all the single drugs, liraglutide is the one that produces maximum weight loss. But phentermine topiramate combination is the one that produces overall maximum weight loss. And there is one more drug that's called lorcaserin that is banned right now. We don't use. FDA has withdrawn its approval for lorcaserin. It's a 5-HT2C agonist, but it is not used anymore. It's a 5-HT2C agonist. It's a serotonin agonist. It's not used anymore. These are the 4 drugs that are currently in the market for weight loss. As far as bariatric surgery is concerned, bariatric surgery, typical indications for bariatric surgery is BMI more than 40. That is also referred to as morbid obesity. Or if the patient is having BMI in the range of 35 to 40, that is, I can write 35 to 39.9, that is also referred to as moderate obesity. Plus, if the patient is having associated comorbidities like type 2 diabetes mellitus or hypertension or problems due to obesity like non-alcoholic fatty liver disease. So in these situations, you can go for bariatric. These are the 2 indications. Comorbidity means diabetes, hypertension, or patients who are having non-alcoholic steatohepatitis. So these are indications for during bariatric surgery. Very common bariatric surgery that is done is the sleeve gastrectomy. That is done very commonly in India. But there are some other surgeries like banding has been done. These are restrictive procedures or Roe and Y gastric bypass. The highest amount of weight loss is generally achieved with Roe and Y gastric bypass only. But that's having a little bit of more side effect profile. That's why usually Indian patients go for that banding or probably they go for that sleeve gastrectomy, which is actually a little bit more comfortable. Banding is completely reversible. Sleeve gastrectomy is not reversible, and row and Y gastric bypass is partly reversible but not completely reversible. But that is completely different. You can learn that in surgery, for that matters. And apart from that, there are some drugs that are supposed to be beneficial in patients with NAFLD. So, what are the drugs that are supposed to be beneficial in patients with NAFLD? Number one, metformin. Considered to be beneficial. It also produces weight loss, but not significantly. Pioglitazone is also considered to be beneficial to an extent. Liraglutide, apart from producing weight loss, it's also considered to be beneficial as such in a patient with NAFLD. These are the drugs you can use in patients who are having diabetes mellitus. Vitamin E is supposed to be beneficial. Then other drugs, fish oils, statins, then AC inhibitors, pentoxifillin, all these things are considered to be beneficial. But vitamin E proven in non-diabetic patients. Non-diabetic patients, surely you can use vitamin D, but all these drugs, whether they're beneficial or not, we have no idea. They are highly controversial. So, but definite benefit or at least potential benefit has been proven with these three diabetic drugs, metformin, pioglitazone, and liraglutide. But in non-diabetic patients, vitamin E has been shown to be of benefit. But other drugs like fish oil, statins, AC inhibitors, and pentoxifillin are, little controversial. And of course, we forgot the exercise, isn't it? Exercise is really, really important. At least minimum exercise that is recommended is at least 10,000 steps per day, or at least 200 minutes per week of moderate intensity exercise. So that is what is recommended: 10,000 steps per day, or at least 200 minutes per week of moderate intensity exercise is what is considered to be optimal. So these are the important things that you need to know about non-alcoholic fatty liver disease. Remember, most common cause of cryptogenic or idiopathic cirrhosis right now in the world is non-alcoholic fatty liver disease only. Clear. So now we are moving on to the last topic of the day, that is autoimmune liver disease. Autoimmune liver disease. As far as exams are concerned, there are very few things that you need to know about autoimmune liver disease. One is, let us see as a comparison, one is autoimmune hepatitis, second one is your primary biliary cirrhosis, and third one is primary sclerosing cholangitis. These are the three major types of autoimmune liver disease for that matters. As far as autoimmune liver disease is concerned, the gender is typically the female. So the female gender is the one that is very commonly affected as far as autoimmune hepatitis is concerned. But only thing that is actually seen in more in males is the primary sclerosing cholangitis. So if you take about the gender, females will be very commonly affected here. PBC, again, females will be more commonly affected here. When you take about this PSC, this is the only place where males will be more commonly affected than females in the first place. That is very important. Now, apart from that, as far as the age group is concerned, there are two peaks are there. Children can be affected as well as adults can be affected. Most of the times, adults will be middle age group. They are the ones who will be affected. PBC, again, typically middle-aged females. And once again, PSC will be typically middle to old age males. So these are the ones who are going to be affected as far as primary sclerosing cholangitis is concerned. Again, how autoimmune hepatitis is going to present? Spectrum is going to be completely different. They can be completely asymptomatic. Later on, they can present with cryptogenic cirrhosis. They can present with cryptogenic, which means without any reason, they'll be completely asymptomatic over a long period of time. Suddenly, they'll come with cirrhosis. Or they can be symptomatic, coming with jaundice, or coming with only constitutional symptoms like fatigue, anorexia, weight loss, and all this stuff. Or they can present with acute liver failure also. Again, the spectrum is completely variable. Or they can come with chronic liver disease also. So in any way they can present. The presentation is completely variable. So asymptomatic presentation with cirrhosis, present just with constitutional symptoms, present with jaundice, can present with acute liver failure, or can present with chronic liver disease, which means the presentation is completely variable. And what kind of presentation? Suppose if you do an LFT, that is what is very important. If you do an LFT, what kind of presentation they generally tend to have is the hepatocellular pattern. LFT will be typically hepatocellular. We have already discussed what you mean by hepatocellular. In general, ALT and AST levels will be elevated. Typically will be more than 3 times the upper limit of normal. ALP can be normal or can be elevated, but it will be less than 2 times the upper limit of normal. So, but typical hepatocellular pattern is this: AST ALT will be elevated and it will be more than 3 times the upper limit of normal. ALP will be elevated, but less than 2 times the upper limit of normal. Primary biliary cirrhosis, typical presentation is pruritus. That's how they come. I mean, they can be asymptomatic also. That's possible. But if they are symptomatic, the common symptoms will be pruritus, and at the same time, more importantly, they will have Zika symptoms. That's very, very important. Suppose in exam, if they give the Zika symptoms, that is dry skin, dry eyes, always think about primary biliary cirrhosis. Any patient with cholestatic hepatitis having a high ALP, having Zika symptoms, is primary biliary cirrhosis unless present, because almost half of the patients will definitely experience this Zika symptoms. Plus or minus the patient can have jaundice. Very rarely they can present with cirrhosis also, but that is not needed for you right now. If you take the LFT, how the LFT will be? LFT will typically show something called as a cholestatic pattern. LFT will typically show cholestatic pattern, which means ALT and AST can be elevated, but typically it will be less than 3 times the upper limit of normal. But ALP elevation is very characteristic. It will be more than 2 times the upper limit of normal. Upper limit of normal. So this is a typical cholestatic pattern. That's how they're going to present. Bilirubin increases variably. If the bilirubin is increased, it will be typically direct bilirubin here. And whereas in autoimmune hepatitis, it can be direct or indirect bilirubin, but very commonly it will be direct bilirubin, indirect bilirubin again. And in patients with primary sclerosing cholangitis, the most important is the history of underlying inflammatory bowel disease, which is seen in more than 85% of patients, which means in exam, unless until they give history of IBD, don't diagnose a primary sclerosing cholangitis, which is very, very important. You need to have this history of IBD. Very commonly, you will have ulcerative colitis, competitor of Crohn's disease. And along with that, they will come with maybe they can have pain because they produce strictures in the extrahepatic biliary tree. So they can come with pain, they can come with jaundice, or they can come with pruritus because of excessive accumulation of bile acids in the body. And once again, they will have typical cholestatic pattern, and where ALT and AST can be elevated, but if it is elevated, it will be less than 3 times the upper limit of normal. But ALP definitely will be elevated and it will be more than 2 times the upper limit of normal. Bilirubin may or may not be elevated, depends again. And what about the antibodies? So because to diagnose autoimmune liver disease, you need to have evidence of autoantibodies. What autoantibodies you can have? So number one, you typically your ANA will be positive very commonly, and ASMA will be positive. This is called anti-smooth muscle antibody. This is the antibodies that are seen in type 1 autoimmune hepatitis, and type 1 autoimmune hepatitis is supposed to be the most common type of autoimmune hepatitis. Or you can get something called as anti-LKM1 antibody, which can be positive in type 2 autoimmune hepatitis, which is very rare. Usually type 1 autoimmune hepatitis is the one that happens in adults. Type 2 autoimmune hepatitis usually happens in children, especially in certain areas in France and European countries you might get. But apart from that, type 1 is the most common. ANA positive and anti-smooth muscle antibody will be positive. And here what antibody? Anti-mitochondrial antibody. That will be the characteristic classic antibody. That is anti-mitochondrial antibody. That will be the one that will be positive in the patients with primary biliary cirrhosis. And what is the antigen here? They will ask you about the antigen. So what is the antigen clearly here? So AMA of M2 type. M2 type. M2 means the antigen here will be the pyruvate dehydrogenase complex, PDC. Pyruvate dehydrogenase, M2 of the pyruvate dehydrogenase complex, that is the antigen. Especially the M2 component of the pyruvate dehydrogenase complex in the mitochondria. So that is what the antigen is, and that is where your antibodies are directed against. So this is a typical antibody, AMA M2, very classic. So this is what is seen in primary biliary cirrhosis. And antibodies are not that important in patients with primary sclerosing cholangitis, which means I don't want to really tell. But if at all you want to see, you can see P ANCA in certain individuals. But remember, you can see IBD-related antibodies. IBD-related antibodies. You know what are the IBD-related antibodies? In ulcerative colitis, typically you will have something called ASCA negative and P ANCA positive. Or in Crohn's disease, you will be having ASCA positive and P ANCA negative. So these are typical IBD antibodies, but P ANCA positivity is quite common, but that is not really important for us. And more importantly, IgG elevation is very, very characteristic of autoimmune hepatitis, very common in exam. And apart from that, IgM elevation is very characteristic of primary biliary cirrhosis. But here, you might have increased IgG or probably IgM. That does not make any significance at all. Yeah. But this is very common question that is asked in exam. So how to remember whether it is anti-mitochondrial antibody and IgM? It's very simple. I just remember by a simple mnemonic, you have something called PBC, that is, you have physics, you have biology, and you have chemistry, and the only thing that is left is mathematics. So you have PBC, max. So remember, the only thing that is left is max, so M. So that's why we think about AMA and IgM here. M stands for M. That's why I remember. This is a mnemonic that you can think about. There's a mnemonic you are going to think about here. And biopsy generally needed only in selective case. You don't need biopsy in all the patients with autoimmune liver disease. But in general, if you take a biopsy, what you really see in the biopsy is you will see interface hepatitis. So that's very classic. In exam, if you get the word interface hepatitis, even though this is not specific for autoimmune hepatitis, but in the presence of ANA, if you get interface hepatitis, that is very classic. It's autoimmune hepatitis only. And at the same time, you will be having this immunoglobulin G secreting, IgG secreting plasma cell infiltrate. IgG secreting plasma cell infiltrate, that's very characteristic. But in exam, don't forget the word interface hepatitis. And what you will get in primary biliary cirrhosis, you will be typically getting ductopenia. And once again, this is a very non-specific finding, but more specific finding is bile duct granulomas. Bile duct granulomas, which means there will be granulomas that will be centered around the bile duct and they'll be destroying the bile ducts. So because of that, you will have paucity of the bile ducts, reduced number of bile ducts. That's what we call ductopenia. It's very classic. And typically what you'll be seeing is here around this small to medium sized bile ducts, you will be seeing onion skin fibrosis, or the duct will be okay, but there will be periductular fibrosis. That's very classical. It's called periductular fibrosis. This is also referred to as onion skin fibrosis. Onion skin fibrosis. That's very classical of a PSC. Is biopsy needed? Biopsy definitely needed in patients with autoimmune hepatitis. Without that, it's better not to diagnose. Here, biopsy is needed in some patients with confusing picture, where you suspect PBC but antibodies are negative. If antibodies are positive but you don't have a picture similar to that of PBC, it's showing hepatocellular picture, not cholestatic picture, but AMA is positive. In case of confusing picture, you might be needing biopsy. Otherwise, if it's a classic cholestatic picture and patient is having AMA positivity, typically you don't need to do a biopsy. So biopsy needed only in some cases. Biopsy, once again, here needs needed only in some cases. I'll tell you where you need biopsy. But almost all cases of AH needs biopsy. Don't diagnose AH without a biopsy. And as far as cholangiography is concerned, cholangiography, you can do either an ERCP or probably an MRCP. Anyone is fine. So typically for diagnostic purpose, we do MRCP. Cholangiography is typically not needed in patients with AH. Even if you do cholangiography, it will be completely normal. Cholangiography, once again, is typically not needed in patients with primary biliary cirrhosis. Even if you do, it will be normal. But cholangiography, definitely it is needed, where you will see strictures of the bile ducts. Stricture of bile ducts. Typically, this is an extrahepatic bile duct disease, so there will be stricture of bile ducts. So MRCP and ERCP can basically identify the extrahepatic bile ducts only. So where in autoimmune hepatitis and primary biliary cirrhosis, being an intrahepatic disease, they don't show any problem in extrahepatic bile ducts, whereas PSC, it's a predominant problem of extrahepatic bile ducts, so they'll be having stricture of bile ducts, and there will be alternative constriction and dilatation, thereby showing something called as a beaded appearance. That's what is going to happen. But please understand, there are 15% of the cases which are called as intrahepatic PSC, where MRCP or ERCP can be completely normal. So this will affect only the intrahepatic bile ducts. So the investigation that analyze the extrahepatic bile ducts like MRCP or ERCP will be completely normal. So these patients only will be needing biopsy. I told you some patients need biopsy. Who needs biopsy? Only those patients who are having or suspected to have intrahepatic PSC. Only those patients you need biopsy. Otherwise, if it clear-cut extrahepatic PSC, which is the most common variety, 85% of the cases, you don't really need a biopsy. And what will be the ultrasound finding? Ultrasound finding is variable here, but the biliary tree will be normal. Biliary tree will be typically normal. Ultrasound, once again, the finding will be variable. The liver finding will be completely variable, but of course the biliary tree will be completely normal. You don't see any dilatation of the biliary ducts. Here, most commonly, ultrasound will show dilated extrahepatic biliary radicals. EHBR means it's extrahepatic biliary radical dilatation will be there, but rarely it can be normal. 15% of the cases, if it's a intrahepatic PSC. If it's an intrahepatic primary sclerosing cholangitis, ultrasound can be completely normal. Otherwise, usually ultrasound will show this biliary duct dilatation. But classical diagnosis through the MRCP or ERCP only. Treatment-wise, autoimmune hepatitis, typical regime is steroids plus or minus azathioprine. This is the typical regime that we prefer, and most important as well. And for primary biliary cirrhosis, typically we are going to use UDCA. That's the best treatment, ursodeoxycholic acid. For primary sclerosing cholangitis, typically we don't know what is the treatment. The only treatment that is available at that time of, end-stage liver disease is orthotopic liver transplantation. That's the only definitive treatment. But even these patients, if they don't respond, the only treatment that is available is orthotopic liver transplantation over a period of time. But we have a definite treatment. Steroids, UDCA, azathioprine, all works better under particular heading. So steroids, usually, I generally in my practice, I had azathioprine along with steroids. It's a very common thing. These are standard therapy for autoimmune hepatitis. And UDCA is a very standard therapy. It prolongs the liver transplantation and improves the outcome and survival in patients with primary biliary cirrhosis. But we don't know the exact treatment for primary sclerosing cholangitis. So at end stage, you can go for orthotopic liver transplantation. But interim, to avoid the strictures and pain and all, you can use some stenting. So biliary stenting can be tried, but this is only palliative. So to relieve the obstruction in the extrahepatic biliary radicals. Apart from that, PSC carries a significantly high risk of hepatocellular cholangiocarcinoma. Cholangiocarcinoma. This is a very important point because many patients with PSC can have an underlying cholangiocarcinoma. Because of that, you have to consider OLT because cholangiocarcinoma is supposed to be the absolute contraindication for doing a orthotopic liver transplantation. So always rule out cholangiocarcinoma before diagnosing a primary sclerosing. Before going for OLT in a patient with primary sclerosing cholangitis. These are the differences between the three most important autoimmune liver diseases. Whatever I have told you here are questions, and whatever may be the facts. So these are the questions that you'll be getting in exams for sure. So I think with this, I'll be closing down this particular session so that we can come tomorrow and discuss the rest of the GI and hepatology. And I think it will be over for the premium students. So at least the syllabus will be over if the GAT is completed tomorrow. And let me come back and discuss tomorrow. Till that, stay tuned. Good night. Thank you very much. Bye-bye. See you.